down the road. And we have hospitals kind of throughout the Wasatch Front. You can see here on the map. If you want to connect with us, those are our websites and our social media handles. So to present myself, I'm Dr. Enrique Feria. I'm an orthopedic surgeon specializing in foot and ankle surgery. I manage both operative and non-operative care for foot and ankle issues. I've been with St. Mark's about 1.5 to 2 years now, and work with the Salt Lake Orthopedic Clinic that's located on campus. I'll be talking to you today about treating your foot and ankle pain. I have no disclosures related to this talk. Really a pretty broad topic to cover in 45 minutes or an hour. So I kind of tried to break it down into 3 different categories of reasons you could have pain in your foot and ankle. And we'll cover some of the most common conditions that in each category moving forward. We'll start with trauma or injuries, and we'll just jump right into it. If you guys have questions along the way, please feel free, interrupt me, raise your hand for those that are here in person, and we'll answer your questions along the way. So starting off with trauma, again, we have sprains, which are essentially injuries to your ligaments. The ligaments are what connect your bones to bone. And typically when you're thinking of sprains in the ankle or your foot, we're talking about low ankle sprains or high ankle sprains. And I'll go over the difference in each. Low ankle sprains being the ligaments on the outside of your ankle. So kind of here you're getting a diagram showing your 3 ligaments on the outside, the most commonly injured ones being the ATFL and CFL ligaments right there. Those are the majority of your ankle sprains, more than 90%. High ankle sprains are injuries to the ligaments that connect your tibia and fibula above your ankle joint. Those are definitely more rare, but can be a lot more significant in terms of maybe requiring surgery acutely. So again, low ankle sprains, that's what you typically think of when you roll your ankle. It's a very common twisting injury to the ankle, happens to be the most common reason for missed sports. People that have ankle sprains, you typically kind of have your foot pointing down and roll over it, and you tend to have bruising and swelling like you see in the picture here. People oftentimes, if it's a severe enough sprain, have a hard time putting weight on it. And again, because of the swelling, they get stiffness in their ankle as well. This is just a video showing you Steph Curry rolling his left ankle. And again, when it's a sprain that bad, it's not uncommon for it to take a few weeks to fully recover from. The mainstay of treatment for low ankle sprains is something we call RICE therapy. So RICE standing for rest, ice, compression, and elevation. If it's a bad enough sprain, kind of the higher grade sprains, we classify them grades 1, 2, and 3. If you fall into the more severe grades 2 and 3, sometimes you require a boot temporarily. I don't like keeping patients in boots longer than 2 to 3 weeks because I do think it ultimately can cause issues with stiffness and weakness in your ankle long term. But for the first couple of weeks, it can be useful. And then ultimately getting patients into physical therapy where they get a chance to work on getting their motion and strength back, and eventually working on something that's called neuromuscular conditioning, where they work on their balance and proprioception. Functional bracing, like a lace-up ankle brace, can also be helpful in the long term, especially for high-risk activities like sports. Like I said, low ankle sprains, the higher the grade, the longer it takes to recover from them. Typically though, from about 6 to 8 weeks, most of these ankle sprains do resolve and patients are able to kind of get back into their normal activity. If they're not getting better, it's important to just keep in mind that you have to look for other things. If patients are still having pain, swelling, stiffness, then that's where getting advanced imaging like an MRI, CT can be helpful. And that helps you pick up some other things that can sometimes be missed initially. The list of things that I listed there are some of the most common things you can find in low ankle sprains that are just not getting better after 6 to 8 weeks. It can be injury to your cartilage, to tendons on the outside of your ligament or your ankle, or a high ankle sprain too. Or you can even have missed fractures that you may not have picked up initially. About 15 to 20% of people with a bad ankle sprain can go on to develop what's called recurrent sprains or chronic lateral ankle instability. These people typically come in complaining of their ankle feeling unstable or loose, like it wants to give out easily, especially when they're walking on uneven ground or rocky terrain. And if that doesn't respond to bracing and physical therapy, then sometimes this does require surgery where you essentially go in and retension or repair those ligaments to make them nice and taut again. Moving on to high ankle sprains. Again, this is typically a more serious injury than your low ankle sprain. It's commonly seen with sudden external rotation of the foot, like you can see in the picture here, where the body's externally rotating over the foot that's planted on the ground. It's rare to see them in isolation. They're typically more commonly seen in the setting of an ankle fracture. And you can definitely expect a longer recovery with these as opposed to your low ankle sprains. And like I said, sometimes these do require surgery in the acute period. This is just showing you an x-ray here on the left, A being kind of an ankle that looks pretty normal, but then when you stress that ankle under x-ray, you can see how there's asymmetry of the ankle joint line that you can appreciate here. This looks nice and symmetric, but then you get to the stress the ankle and you see how it gaps open here, and these two bones are starting to splay apart. That's indicative of an unstable high ankle sprain that needs surgery. And then on the right, just MRI images showing a more subtle high ankle sprain that, again, if it's unstable, it needs to be fixed. Typically, the way I fix these using a device called a tightrope, which is just a strong suture that's anchored on either side of your ankle with metallic buttons, and that kind of helps stabilize your ankle to allow those ligaments to heal over time. Moving on to strains. So strains are injuries to tendons, and tendons are what connect your muscles to your bones. A very common one that I see a lot in clinic is an Achilles tendon rupture. This is usually due to a traumatic injury during sports. It's more common in men and commonly seen in your 30s and 40s, especially in people we call weekend warriors who don't necessarily participate in sports often, but then they're playing a pickup basketball game and they rupture their Achilles. Also, other risk factors for an Achilles rupture, steroid injection near the Achilles tendon definitely predisposes you to a rupture, as well as fluoroquinolone antibiotics, which is a specific family of antibiotics that can predispose you to Achilles ruptures. Just some clinical pictures here showing you how we identify these in the office. Really, patients, when they present with an Achilles tendon rupture, oftentimes describe feeling a pop or this sensation like someone kicked them in the back of the leg, even though no one's around them. There is a brief period of pain initially, but the pain goes away pretty quickly. So these can sometimes be delayed in diagnoses just because they have pain for the first couple of days, but then it gets better and they don't seek medical care right away. And then obviously an Achilles rupture that's diagnosed weeks late ends up being a much bigger problem than one that's diagnosed right away within 24, 48 hours. On exam, you'll notice a palpable gap on the Achilles tendon. That's what the arrow on the left picture is pointing to. And when you have patients lay on their belly on the exam table, normally the Achilles tension causes your foot to lay like it is right here on the backside. When it's ruptured though, your foot tends to drop in what we call more dorsiflexion. And then you can see here, this is called a Thompson test, and this helps us diagnose Achilles ruptures where in a normal individual, if you squeeze the calf at the mid-lower leg, it causes the foot to move downward. When you have an Achilles rupture, there's no motion whatsoever. So just a helpful diagnostic tool for me in clinic. The debate is whether these need to be treated surgically or non-surgically. Again, this has been a debate for the last couple of decades, and we still don't have the right or wrong answer. There's pros and cons to each. Typically, non-surgical treatment involves fewer complications because you don't have the risks of anesthesia, less risk of infection or wound healing since you don't have an incision. But historically, there was a higher risk of re-rupture in the long run. That's sort of been disproven more recently. Some tears, especially the ones that are higher up near the muscle, can be treated non-operatively, and those do well. And certain patients, especially your sedentary or medically frail patients, do better with non-operative treatment. In terms of surgery, there are some studies that show that there are some pros to doing surgery, such as quicker return to sports or heavy labor. better strength in the long term. And typically nowadays, historically, we used to fix these with big incisions that put you at a higher risk of infection, wound complications. Nowadays, if I fix them within the first couple of weeks of the rupture, I'm doing it through a small incision. It's a couple centimeters long and definitely decreases the chance of any wound complications or infections. And you get a good solid repair with it. And that's just an image at the bottom showing how I repaired those with a special device that allows me to shuttle the sutures percutaneously. We'll talk about peroneal tendon tears. These are tendons on the outside of your ankle. These can be injured kind of similarly to low ankle sprains, that same mechanism of injury, but also can be torn from degeneration or attritional wear. This is just showing you a diagram. Those tendons are located again on the kind of backside, outer part of your ankle. You have a couple, your peroneus brevis and your peroneus longus tendons. The peroneus brevis is the one that's more commonly torn just because it's closer to the bone, so that it's thought that it can kind of have some frictional wear by rubbing against the bone. And again, just MRIs are typically how you diagnose these. The x-rays aren't going to show you much, but if you get an MRI, you can definitely pick up tears of your peroneal tendons. And again, typically your peroneus brevis is the one that's going to be injured the most. You see longitudinal tears, and there's typically pain kind of on the posterolateral aspect of your ankle. And again, MRI or ultrasound is what's helpful in diagnosing these. Treatment is generally conservative, at least initially. You might temporarily place them in a boot for a few weeks to let the acute pain settle down, anti-inflammatories, rice therapy like we mentioned before, and then physical therapy. If pain doesn't improve after several weeks or a few months of conservative treatment, then sometimes you have to do surgery where you go in and really, depending on the type of tear, whether you primarily repair it or cut out the torn portion of the tendon and tie the healthy portion to the other tendon, there's different ways of fixing it. It really just depends how it looks at the time of surgery. Dislocation of your peroneal tendons. That's a little bit different entity than just a tear. It's more commonly seen in younger patients. They'll present with a history of ankle instability, clicking, popping, and pain kind of in the same area. Let me see if I can get this video to play. You can kind of see there, this is just showing you how they dislocate. So with the right movement, you can see those tendons kind of slipping in front of the bone back and forth. And when you have something like this, that's when you know there's been an injury to the ligament that keeps those tendons in place behind your fibular bone. And this is just showing you an x-ray of what that can look like. That little fleck of bone that you're seeing here on the outer part of your ankle is just indicative of that ligament tearing a piece of bone off and now allowing those tendons to dislocate back and forth. And an MRI helps you diagnose that. This tendon normally should be located behind your fibula, and you can see how it's slipped out to the side there. When you see this type of problem, non-surgical treatment isn't that great. Patients don't do too well with it, but if you are going to treat someone non-surgically, you want to cast them and protect weight bearing for about 6 weeks. The reason it doesn't do so well with non-surgical treatment, it's hard to keep those tendons kind of reduced behind the fibula in a cast. So it tends to, over time, want to slip back out. So oftentimes this is repaired surgically. And that's just a diagram showing you how you essentially go out and burr out the groove for those tendons and make it deeper to keep them in place. Moving on to fractures or broken bones. So ankle fractures, very common injuries to the ankle, generally occur from a twisting mechanism. These are diagnosed on x-ray. And again, you get a whole variety of flavors. They can be subtle, like the ones on the left, where you really have a single bone that's broken, and until you stress the ankle, you really can't appreciate the instability of how that fracture moves and the joint displaces outwards. And then obviously you have your more severe ones where you can actually dislocate your ankle, and those are a little bit more urgent, and you want to reset the bone quickly so you don't cause more harm to the surrounding soft tissues. And again, just some clinical pictures of how ankle fractures, if they're bad, they can look bad. And on the left picture, you kind of have part of the fracture that's tenting the skin here. I don't know if that's easy to appreciate. If it's a bad enough injury, you can definitely develop fracture blisters like that middle picture. And then obviously you can get what's called an open fracture where the bone sticks out of the skin, and that becomes a surgical emergency where you want to get to that within the first 24 hours to wash it out and put the bone back where it needs to be. If it's going to be non-surgical treatment, this is typically reserved for your more isolated fractures, single bone fractures with very little displacement under 2 millimeters, or it's simply patients who are unfit for surgery. More commonly though, if there's any displacement or any instability or open fractures like I showed you, this is going to be surgical where you go in, fix the bones with plates and screws. And just showing you here different ways of fixing it. The picture on the left is what's called an external fixator. And that essentially is a temporizing measure where we put pins and bars that connect the pins on the outside. And that's done if there's a lot of swelling initially, just to give the soft tissues time to settle down, and then you come in and fix it with plates and screws on the inside, like you can see in the rest of the pictures. And again, depends. You can break it in one place, 2 places, or even 3 places. And generally, you kind of fix everything depending on how badly displaced it is. Moving on to Lisfranc injuries. These are injuries to the midfoot, and specifically a ligament that helps maintain your arch and is very important for stability that you can see here. That's your Lisfranc ligament on the inside of your foot. Again, these are typically diagnosed with X-ray, and these injuries, more often than not, are going to be surgical. It's rare to have a simple sprain of your Lisfranc ligament that can be treated non-surgically. They can be caused either by direct trauma, like motor vehicle accidents, crush injuries, or indirect trauma, falls, sport injuries. And again, patients typically present with severe midfoot pain. They can't put weight on that side. On exam, if you see bruising on the sole of your foot, that's very concerning for a Lisfranc injury. So I typically have a very low threshold to get CT scans or MRIs. If there's bruising in your sole, on the sole of your foot, and the X-rays aren't conclusive, then you get advanced imaging. And again, like ankle fractures, they come in a variety of flavors. They can be subtle, like the one on the left where you see a little bit of a step off here. Otherwise, looks pretty good. Then you get your more severe ones where the foot, it not only is the Lisfranc ligament injured, but it has all these fractures and you get dislocation of the midfoot joints. And again, a little bit more of a urgent surgery when it's that bad, where you want to go in and get everything lined up better to take the tension off the soft tissues. The way you fix these, a combination of screws, plates, or plates and screws together, it really depends on the severity of the injury. And again, that they can be fixed in many ways. So moving on to our next category here, degenerative conditions, things like arthritis, and we'll just dive right into it. Ankle arthritis, it's degeneration of your ankle joint where you start to lose the cartilage lining of your ankle joint. In the ankle, this is typically more commonly due to what we call post-traumatic arthritis, as opposed to your hip or your knee where you get wear and tear. Typically in the ankle, post-traumatic arthritis simply means that you had some traumatic event in the past, whether it was an ankle fracture or an ankle sprain or repeated sprains that over time has led to cartilage injury and cartilage wear. And that's just an X-ray at the top showing you what normal looks like on the left and what ankle arthritis looks like once you've kind of lost your joint space and are starting to tilt outward. And again, just a side shot of that X-ray showing you complete obliteration of that ankle joint. Patients typically present with pain with weight bearing. So standing, walking causes pain. They don't really have much pain at rest. They'll start to lose motion over time and become stiff, and they also complain of swelling. And then on exam, you'll notice swelling at the joints. They'll have pain with range of motion and less range of motion as opposed to the unaffected side. And over time, if they start to kind of tilt, they can get this angular deformity, whether they tilt outwards or inwards, both are possible. Treatment for ankle arthritis initially is going to be non-surgical. And again, once you have arthritis, regardless of where it is, the only cure for it is surgery. These other things we do from a non-surgical standpoint are really meant to manage your symptoms as opposed to cure the underlying arthritis or reverse it. But typically, initially, you always want to start non-surgical, and this is a combination of things where we do anti-inflammatory drugs like ibuprofen. bracing, you use something like this called an ankle foot orthosis, which kind of helps keep your ankle locked up and mitigates the pain. You can try injections. Typically in the ankle, that's going to be steroid injections. You can get these every 3 to 4 months as needed. They tend to lose their efficacy over time if you repeat them. And again, you don't want to do them too often. So I generally recommend going at least 3 to 4 months in between injections. And then surgical treatment for ankle arthritis. Once you've failed conservative management, your pain's worse, and you're just having progression of your arthritis, then oftentimes you need surgery. And when it comes to ankle arthritis, that either revolves around doing an ankle fusion or an ankle replacement. Not everyone is a candidate for an ankle replacement. I know everyone asks me if they can have an ankle replacement. I wish everyone could. There really are some certain criteria that you want to meet. The younger you are, or if you're overweight, you're not going to be a good candidate for an ankle replacement. Typically, I don't recommend doing an ankle replacement in anyone younger than 50 to 55 years of age. And you also want to make sure that they're not overweight. BMI greater than 40 is generally a cutoff for me. The other thing to consider is if they have too much deformity, either way, then oftentimes that also negates the possibility of doing an ankle replacement. But an ankle fusion is still a pretty successful surgery in getting rid of your pain, and they each have their pros and cons, but both are very successful surgeries at getting rid of the pain from the ankle arthritis. And then just X-ray is showing you on the left an ankle fusion with plates and screws, and then an ankle replacement on the right. We're moving on here to the great toe. Hallux rigidus, a fancy way of just saying it's great toe arthritis of the joint that's highlighted here in red in the picture. And it's the most common location of osteoarthritis in the foot. Generally what you start to see earlier during the early stages is bone spur formation and cartilage wear on the top part of the joint. So kind of right here, and then over time, it can progress to involve the entire joint. Patients present complaining of great toe pain. That's typically worse when they're pushing off with their toes, and that's because as they push off, those bone spurs are kind of hitting each other that you have on top of your great toe. They'll have swelling, stiffness. On exam, you can notice a prominence on top of that joint. That's what the arrow is pointing to there, and they'll have limited flexion going upwards. And again, that's due to those bone spurs that form on the top of your joint. Treatment, again, always start non-surgical, and kind of similar to your ankle arthritis, it revolves around injections, anti-inflammatory drugs. It helps to try and avoid activities that lead to too much flexion of your toe upwards. And they make this special orthotic called a Morton extension orthotic, which is pictured here. It extends past that big toe and kind of helps minimize the amount of motion across your big toe, which can be helpful in like the early cases of great toe arthritis. But then again, as it progresses over time, those aren't as helpful anymore. And then again, you might reach to the point where if all else fails, you may end up having surgery for this. And this again, basically comes down to two different surgeries we do. Chylectomy is simply basically going in and cutting off the spurs on top and part of the joint and help decompress that area. You can see how those spurs at the top are pretty significant, but once you take them off, it actually decompresses the joint and gives you more mobility. That's helpful in the initial stages. If it's progressed to the point where the whole joint is involved and it's painful, then you do a fusion of that joint with plates and screws. Moving on to Achilles tendinopathy. This is just degeneration of your Achilles tendon. This can happen both at where it inserts on your heel bone or higher up within the tendon. It leads to pain and tendon thickening right at the insertion, and over time you can start to see these calcifications on the back side of your heel bone, oftentimes associated with what we call a Haglund deformity, and that's just like a protuberance of your heel bone that is just, some people have it, some don't. It's just the way you were made, and that can definitely kind of cause symptoms to be a little bit worse as this is rubbing on the inside of your Achilles with motion. Patients present with pain on the backside of their heel. They'll oftentimes have this little bump, and that's from the thickening of the tendon as well as the calcifications, and that over time can definitely get bigger in size. They'll complain about swelling, stiffness. On exam, they'll be tender right over where that bump is. And Initially, again, always start conservative treatment first. So non-surgical treatment can be helpful. You basically want patients to avoid wearing shoes that have pressure over that bump. So open heel shoes can be helpful. Physical therapy is the mainstay of treatment, though, and you want to do something called an eccentric strengthening training program, where this picture is kind of showing you an example of what that looks like, where you go up on your tippy toes, and then as you're kind of coming down and slowly coming down, you're stretching it, but also working on strengthening the calf muscle simultaneously. That's what eccentric strengthening involves. And then again, if all else fails and it's been a few months, you've done the therapy, medication, shoe modification, then sometimes you have to go in surgically and essentially clean out all the calcifications and degenerative tendon. You get rid of that bone bump on the back of your heel, and you can kind of see the difference between the x-rays left to right here, what pre and post surgery looks like. And again, patients do well. If they fail conservative treatment and they're still having symptoms, patients tend to do well. It's a prolonged recovery. It's about 3 to 4 months before you can kind of get back into your prior level of function, if you will. Non-insertional Achilles degeneration, again, same thing as with the insertional variety. It just happens a little bit higher up. It's thought to be due to poor blood flow in that region of your Achilles. Similar symptoms, you'll have pain, swelling, it's just a little higher up. And again, on exam, you'll notice thickening of the tendon and pain at that particular location. Again, non-surgical treatment, very similar to what the insertional variety is. In terms of surgery, it's reserved for those who don't respond to physical therapy. And generally, again, you're going in, cleaning out all the degenerative tendon and repairing what's left. Plantar fasciitis, very common condition. This, again, the plantar fascia is this thin layer of connective tissue that goes from your heel bone all the way to your toes, and it helps support your arch. And plantar fasciitis is essentially a painful heel condition that's caused by inflammation right where the plantar fascia starts on your heel bone here. Some risk factors: obesity. If you have tightness in your foot and calf musculature, it can predispose you to plantar fasciitis. And if you're a weight-bearing endurance athlete, whether you're a runner or dancer, that can also predispose you to it. Patients typically complain of sharp heel pain on the bottom of their heel. It's typically worse with the first few steps in the morning. Initially, patients may want to walk on their tippy toes to avoid putting weight on their heel. It gets better as they kind of loosen up and walk more, but then at the end of the day, after standing and walking all day, it can get worse again. And on exam, they'll be tender right where that picture is pointing to. That's kind of where the sweet spot is for plantar fasciitis. Oftentimes, it's also seen in conjunction with calf tightness. So it's common to see patients who have plantar fasciitis and tight calf. X-rays and advanced imaging like an MRI, truly in plantar fasciitis, you don't need them to diagnose it. It's more of a clinical diagnosis, but it can help you rule out other reasons for the heel pain. And the mainstay of treatment is non-surgical. I try to tell patients that it's a frustrating condition because it takes a while to get better. It really isn't uncommon for patients to have symptoms that last anywhere between 6 to 12 months. But for the vast majority, 90, 95%, it resolves over time. And especially if you do the stretching program that kind of revolves around not just doing plantar fascia specific stretching like that picture on the top left, but also calf stretching. You don't need any sort of special orthotic for it. Really, at most, if anything, you can get these over-the-counter heel cushions to provide a little bit more padding for the heel. And the other thing that can help is using night splints. Inherently, when we sleep, we tend to relax our feet and have it kind of be in what we call plantar flexion. That night splint just keeps your Achilles tendon stretched overnight and can be helpful. Non-surgical treatment too, if it's been 3+ months and you've done the stretching, medications, the heel cushions, and you're still having symptoms, you can do what's called shockwave therapy. It's essentially like a mini jackhammer that's providing these waves to stimulate healing to the underlying soft tissues. And it's something that some physical therapy places offer, and it's been FDA approved for treatment of plantar fasciitis. Surgery, again, it's rare that you need surgery for this. It happens. I will say I don't typically consider doing surgery for plantar fasciitis unless it's been at least 9, 12 months and they failed everything else. Stretching, the shockwave therapy, and that surgery basically revolves around going in there endoscopically and partially releasing the plantar fascia. Moving on to the last category, we're going to talk about deformity, and there's a few things I'll touch on here. Progressive collapsing foot deformity is essentially just flat feet. Some people inherently have flat feet, other people have high arches, and for whatever reason, some people can go their entire lives with flat feet and not have issues. Other times, patients start to develop pain over time, and this is just showing you clinically what that looks like. Oftentimes, it's caused by your posterior tibial tendon, which is your arch tendon, becoming degenerative and not working anymore as you get older. Earlier on in the disease, it really kind of is caused by inflammation and sort of degeneration of that arch tendon. And as it becomes stiffer and stops working, then your arch starts to collapse. And then over time, as it collapses, that's when you start to notice the rest of the deformity that comes with having flat feet, which I'll touch here shortly. So symptom-wise, initially, it's going to be pain on the inside of your foot and ankle, kind of on your arch, kind of right over where that painful tendon that's not working is. Then as you progressively lose your arch and start to get more deformity over time, then you start to develop pain on the outside of your ankle. And that's because as you're flat and your heel kicks out, that heel bone starts to impinge on your fibula, and that's what causes the pain on the outside of your ankle. So we call it flat feet, but really the deformity is involving a lot of things. So yes, your arch collapses and you have what we call pes planus or flat foot, but it also kind of forces your heel to kick out into what we call hindfoot valgus, which is kind of what you're seeing here. When you're looking at a patient from behind and they have a lot of what we call that heel going into valgus, then you start to see more of their lesser toes, and that's what we call a positive too many toes sign clinically. And because they're kicking out into what we call valgus, it kind of forces the forefoot to compensate and try to turn in, like you can see here, in order to be able to touch the ground. And then over time, as it gets worse, and again, your forefoot starts to swing out too. And just samples of x-rays of what that looks like, A being what a normal x-ray typically looks like. And as you start to get flat, you can kind of see this line is typically collinear throughout your foot. And as you're getting flat, you can kind of see how that starts to dip down. And on this x-ray, looking at your foot from the top, you can see how the forefoot's swinging out and you're getting uncoverage of this bone right here. Non-surgical treatment for this is typically revolves around custom orthotics, especially in flexible flat feet. So if your deformity is still flexible, that's when custom orthotics tend to help the best because they can kind of help restore your alignment more to neutral. If you get to the point where your deformity becomes more rigid, at that point, custom orthotics are a waste of your money. And you can try and use bracing like this ankle foot orthosis that's pictured here. But oftentimes, if your symptoms progress and you're still having issues, it's not uncommon that you need surgery. And it's essentially what you're doing with surgery is reconstructing your foot, whether this is done through cutting the bones and transferring tendons or fusing joints to get your foot in better alignment. Both depends on the progression of the disease. If you still have a flexible deformity, then we tend to do the reconstruction by cutting the bone and transferring tendons. But if you're more rigid, then you end up getting fusions. Like at the top here, you can see an example of what a fusion looks like before and after surgery. And then this is showing you kind of before and after flat foot reconstruction. And again, patients typically, it's a 4 to 6 month recovery, I tell them, from something like this. So it does take a while to recover. Cavovarus foot, this is just your high arch foot. Again, this is commonly caused by either neurologic or traumatic problems. And you can see it in kids, you can see it in adults, and it's just cavus means a high arch. And hindfoot varus, as opposed to what happens in flat feet where you kick out, your heel kicks in with a high arch. And again, commonly due to a neurologic condition. It can be seen on one side, both sides. It can also be due to an old fracture. but that's kind of what it looks like here. You can see how a unilateral case where the left foot's normal and the right foot, you can kind of see, kind of appreciate the high arch here and how the heel's kicked inwards. Patients who have high arches, they tend to have pressure points on the sole of their foot. So if you look at the diagram, normally your weight is kind of evenly distributed throughout the sole of your foot. When you tend to be high arched, you really have pressure points along the outer border of your foot and right underneath your big toe. And that can oftentimes lead to these painful calluses like you see in the bottom two pictures here. And this is just kind of talking more about what the deformity involves. Again, that circle is kind of just pointing out the heel. Typically, when you're looking at someone from the front, you shouldn't be able to visualize their heel. That's what we call a positive peekaboo heel sign, where you're able to kind of see the heel from the front. But yeah, the deformity revolves around having a high arch. The bone that goes to your big toe is just pointing down more, and then your heel kicks in and your forefoot kind of swings inward, if you will. And you can kind of appreciate how that would cause you to put more weight on the outer part of your foot. Coleman block test is just something we use clinically in my clinic to determine whether the deformity is rigid or more flexible, and it kind of helps guide how you would treat these surgically. And that's just showing you x-rays again. Normally that red line should be nice and straight, and you can see how with someone who has high arches, how you can see that starting to point upwards. And again, normally on your foot x-rays here, your metatarsals are nice and evenly separated, but you start to see them kind of stack on top of each other on x-ray when you have high arched feet. Non-operative treatment, similar to flat feet, custom orthotics are very helpful initially if you have a flexible deformity. But then again, if the orthotics over time aren't helping, then sometimes you go in surgically and essentially reconstruct the foot and make it a more normal arch. And that again is a combination of soft tissue work as well as cutting the bones and realigning them to kind of give you a more normal looking shape, if you will. And again, similar to flat feet, it takes 4 to 6 months to recover from something like this. Finally, last thing I'll touch on, something very common, what we call Hallux Valgus, but what's known as bunion deformities. These are very common, more common in women. There's definitely a genetic predisposition to these, and some things that put you at risk of having it. If you have loose ligaments or flat feet, you're definitely at higher risk of developing a bunion in the long run. And people who wore a lot of high heels or tight shoes that have a narrow toe box, or over time, it's not uncommon for them to develop bunion deformities. And again, this just kind of showing you a diagram of how that looks like when you go from normal, a cross section of your big toe from normal on the left to bunion on the right. As you start to tilt, the toe starts to tilt outwards. The tendons are all shifting position and just making the deformity worse over time. Patients present with difficulty with shoe wear is a big one. So they come in basically saying their shoes don't fit anymore, they feel tight, they're causing pressure right over where that bunion is, and you can see they're highlighted in red. That's where the pain is. On exam, you'll notice that the big toe is, again, kicked out and sometimes rotating. And this is just showing you x-rays of what normal versus something with a bunion. There's different angles we measure that help us determine the severity of bunions, and that just kind of shows you that normally your toe is almost nice and straight, and you can kind of appreciate here a 37-degree angle is pretty significant. When we treat these, first line is always going to be non-operative, and first thing we do is tell patients that they need to get shoes that are going to fit and give their toes plenty of room, and that oftentimes involves wearing a wide or open toe box shoe. Spacers are helpful, or pads, kind of like pictured here, where you can put a little gel spacer in your first web space separating your first and second toes. Helps keep your big toe aligned so it's not bullying the rest of your toes. And then this little silicone pad here protects the bump there so it's not rubbing on the inside of your shoes. Eventually, though, if these non-surgical treatments don't work and you're still having pain, or let's say that you really get to the point where the bunion is so severe that you literally can't find any shoes that fit you anymore, then at that point, it's not unreasonable to consider surgery. One thing I will say is you never want to have surgery just purely for cosmetic reasons. Those people just won't be happy. It's not surgery that's easy to recover from, and if you're just having it purely for cosmetic reasons, you're not going to be a happy camper in the long run. The goal of bunion surgery is to relieve your pain by straining the big toe again. And this is just showing you a picture. I tend to do these using a new technique that's minimally invasive, where you literally go in and fix the bunion with 4 to 5 poke hole incisions, and you really can hardly even see the scars afterwards. That's a difference between preoperative and 2 weeks out, and really you can see how the toe is nice and straight again. And if you look at the scars, really it ends up being like 4 or 5 little poke holes like that, as opposed to how we traditionally used to fix them with bigger incisions. That's kind of just the system I use. Again, it just, with the tools we have nowadays in technology, I mean, the fact that you can fix a bunion with kind of 4 or 5 little poke holes, we've come a long way from how we used to cut these open from here all the way back. So that's just how a patient looks like before and after, both clinically and on x-ray, and you can see the difference between them having a bunion to going nice and straight again. I think that's all I have for you guys today. So if there's any questions, I'd be happy to take those now, or go ahead. Well, I will tell you that a lot of it, the question was for those who are following online virtually, what can we do to prevent these things from happening to our feet? I think ultimately a few things. I think it's important to proper shoe wear. I do think it can help, even not necessarily just custom orthotics if you have a deformity like flat feet or high arches, but just wearing shoes that are supportive. It's for bunions, for instance, not wearing high heels and tight fitting shoes. Those can definitely help. And then ultimately, just if you're having pain, make an appointment to see a foot and ankle specialist. It's better to catch something early and deal with it early, as opposed to just delaying the inevitable and letting things progress over time. So I think if you're having any sort of pain, make an appointment, come see me. We'll get x-rays, we'll do an exam and see if there's anything that needs to be done in order to prevent it from deteriorating over time. And same with arthritis. If you catch arthritis early on, there's definitely, like, the bracing can help slow the progression. It will inevitably progress over time, but it definitely can help slow the progression if you treat it early. So just a few things to keep in mind. Yes.
Strengthen your ankles. Anything to prevent that rolling?
They are. So the question was if there's anything that you can do to strengthen your ankle to prevent it from rolling. There is, and that's where physical therapy comes into play, because there's definitely, specifically for when you have that lateral instability where you tend to roll and you feel like your ankle wants to give out. Your ligaments may be incompetent, but that doesn't mean that the tendons or muscles that help stabilize your ankle can't compensate for that. And the peroneal tendons that I mentioned in the talk today, those are actually important, what we call dynamic stabilizers of your ankle. So if you do have loose ligaments, if you work on strengthening your peroneal muscles, which are the ones who kind of help you go up and out with your ankle, that can sometimes add more stability to your ankle. So doing physical therapy and focusing on peroneal muscle strengthening specifically can give you more stability to your ankle. Yes. Yes. They have good arch support. So the question was, if you have flat feet, does it help to use the good shoes or kind of have arch support? Yes. In general, I would say it's a little tricky because some patients, like I said, can go their whole lives with flat feet, and for whatever reason, they never have pain, never bothers them. And it's obviously in that case, I don't think it's necessarily needed to have the custom orthotics, because they can cost quite a bit of money, but it generally doesn't help. It doesn't hurt to at least use shoes with good arch support. I mean, you can get arch support or even over the counter arch supports that aren't very expensive, and It may or may not, but it may help mitigate the problem in the long run. So yes, it may be helpful to at least consider shoes with good arch support. You're welcome. From statin meds. So that I'm not aware personally of statin medications. Those are typically the ones you use for hypercholesterol if your cholesterol levels are too high. And to my knowledge, I'm not aware that they specifically cause ankle pain or swelling. So I would say if they're having any of that, it probably at least warrants coming in to have their ankle formally looked at, get x-rays, and make sure there's nothing else going on that could be explaining the cause. Yes.
Here, slide with the high arches.
Yeah.
It says something about compartment.
Oh, here. I think it was for the high arches, right? Let me go back there. So what can happen, and the reason I have that up there, if you missed compartment syndrome, say you had an injury to your foot associated with like a heel fracture or something like that, and there was compartment syndrome, and at the time that wasn't treated or was missed for whatever reason, that in your foot, that leads to contracture of the muscles. And when they contract, that's what causes the high arch. So it's kind of like a consequence of missed compartment syndrome of the foot. It can cause high arch and clawing of your toes in the long term. Yeah, you're welcome. That's a good question. Yes. Yes. So oftentimes if you have hammer toes, can be seen in conjunction with what we call either subluxation or dislocation of the joints right in front. And if that happens, then that hammer toe is essentially sitting on top of the knuckle of your foot, if you will, and driving that knuckle down, and it causes a lot of pain and swelling in the ball of your foot. You can try using different types of orthotics that are meant to help offload the area where you're getting pain in the ball of your foot. They're called metatarsal pads. If that doesn't help, then sometimes you go in surgically and essentially correct the hammer toe and straighten out the toe again to take the pressure off that knuckle. So there are options. Yeah. Mm-hmm. On the side of your foot? On your toe side? Well, just guessing without looking at your feet. She's asking why she has pain on the outside of her foot and sometimes kind of like by the big toe underneath her. So if you are high arched, like I showed here, sometimes what happens with high arched people, that's just one explanation. I'm not saying that's what you have, but people tend to walk like this. I'm exaggerating, but you tend to put more pressure on the outside of your foot, and that can cause pain kind of on the outside of your foot. But simultaneously, your big toe is kind of pointing down more too, so it can cause pain underneath your big toe. So that could be one reason. It could be several things. So it really, if you're having pain that's kind of persistently there, you want at least someone to look at your feet to see if maybe there's some malalignment or deformity. Maybe it's something else. So oftentimes what can happen too, if you have high arch feet and you're putting too much stress on the outside of your foot, you can start to develop stress fractures over time just from like the amount of pressure you're putting on that area. So it could be a few things. Depends on, yeah, I would say depends on the insurance. I don't know if you have insurance, what your copay would be, but at the very least, getting an appointment to have someone look at your feet, clinically look at them and get x-rays at the very least, just to tell you if there's any reason in particular that you have. I mean, I don't think it's a bad idea. Yeah, go ahead. Yes. Mhm. Yeah. So correct. So basically, well, it depends what you're fusing, but the whole point of a fusion is essentially basically getting rid of the joint and making two bones one. So depending on what you're fusing, so for big toe arthritis, if you end up fusing that, you lose the mobility across that joint, but you still maintain it through the tip of your big toe, for instance, but that other part doesn't move. More often than not, if the arthritis is so advanced, that joint's already not moving much to begin with. So like with arthritis, which is a common reason to do fusions, as that advances and progresses over time, you start to get stiff and lose motion inherently with the arthritis. So really what happens is you're getting rid of the rest of the motion, which isn't that much that's left, but you're getting rid of the pain. Because what hurts is that arthritic joint. Once you do the fusion and you essentially have one bone instead of two, there's no reason to have that pain anymore. So in certain cases, fusions are helpful to get rid of pain. Flat feet, for instance, or high arched feet, when they become rigid, meaning you can't correct the deformity anymore, that's oftentimes because they've developed arthritis over time. Same concept, like once you have a rigid, stiff foot to begin with, the fusion's not really gonna change much of your mobility, but it's gonna help correct your foot shape and get rid of your pain.
It has another effect. Like she said, maybe
So I will tell you, a fusion for something like to correct a high arch foot that's rigid, for instance, if done correctly, it should not cause more stresses on the outside or inside of your foot. Because like what's important when you're doing these surgeries, and this is why it's an easy surgery to do wrong, right? And I'm not saying that doesn't happen, but the important thing is when you're doing the surgery, you want to make sure that the foot is what we call nice and plantigrade, where you're able to have the normal tripod weight bearing in your foot, which is between your heel, your big toe, and your little toe. It should be nice and flat. If you don't have that at the time of surgery, patients aren't going to do well. I'm very OCD when I'm doing these type of surgeries where I check that like constantly throughout, and I want to make sure the foot is nice and flat so that that doesn't become an issue causing pressure points in any particular area. But it can certainly be done wrong, and I've seen it where like a fusion's been done wrong and now they're putting too much weight and you basically have to go in and redo it. Yeah. I may be biased, but I think orthopedic, when it truly comes to bony work, I mean, I just think we have a different level of training than podiatrists. Essentially, as an orthopedic foot and ankle surgeon, I still did an orthopedic residency for 5 years and then went on to further specialize specifically in foot and ankle surgery. And I just think there's, I mean, obviously a discrepancy in the amount of training. And again, I may be biased, but I would say for things that I talked about today, if it were me or a family member, I would always tell them to go see an orthopedic foot and ankle surgeon. You're welcome. It can be. It definitely can be, especially, so high arched, good example. If people are high arched, they tend to wear out the outside of their shoes more. If you're flat footed, you wear out the inside of your shoe more. So yeah, if you've noticed that you're looking at your shoes and you're wearing out one side more than the other, it can definitely indicate that you're either, whether it's because of your alignment or because you're compensating subconsciously or consciously because something hurts, it can definitely be indicative of something going on. I would say, if it's just shoe wear for now, it's probably okay to just keep observing it. But like if the minute it starts bothering you or becomes painful, I think at that point, that on top of having the abnormal shoe wear, you got to go see someone that can look at your feet, get x-rays, make sure that everything looks good. You're welcome. Yeah. Yes, it is. So is it bad to go barefoot with plantar fasciitis? Yes, often. And again, because it's, especially initially when you're getting like the severe pain, it helps to have some support or cushion underneath your heel. And that's why like shoes or even having like kind of that over-the-counter heel cushion can help. If you're barefoot, and again, the pain with plantar fasciitis typically is bad in the morning because people get out of bed and are walking barefoot too. So probably at least initially, not saying you can never walk barefoot again, but initially then when you're going through the first few months and having a lot of pain, it's probably best to have shoes.
Shoe recommendation?
I get that question a lot. I think everyone's different. I don't necessarily like to give a specific shoe brand that works, because like everyone's going to have a different shoe brand that works for that particular patient. But personally, I think Skechers, Hoka, New Balances are good brands, and they make good shoes that for most people tend to work. So a stiff. I would tell you that doesn't necessarily make a huge difference. I think like I was saying with plantar fasciitis, it's not really the type of shoe or orthotics that are going to make a difference. More than anything, like I said, if you need some cushion, the over-the-counter heel cushions are more than enough. Don't ever let someone convince you that, especially if your foot's normally shaped, that you need custom orthotics for plantar fasciitis. It's a waste of your money. But ultimately, it really is just getting the appropriate cushion on your heel that's going to help make the biggest difference. Yeah, yeah. I mean, what I showed is pretty dramatic. Yeah, yeah, yeah. Gotcha. Do they? Well, be happy to take a look at this. Yeah, yeah, yeah. Here you are. Yeah, that's a good. That's a good. Yeah. Yes, I mean, that's actually a good thing. I should have mentioned that. I tell patients oftentimes to do that. You get a water bottle, freeze it, and then you're rolling on your arch, and you're both massaging and icing simultaneously. So you kind of kill two birds with one stone. But that's a uh, very good thing to bring up. Yeah, yeah. So like the calf muscle tightness is very common with plantar fasciitis, and oftentimes they kind of go hand in hand. I always kind of explain it like your calf muscle and Achilles tendon almost kind of blends into your plantar fascia for like kind of the back of your heel and then underneath your heels. So it kind of makes sense to me that they go hand in hand. Is that it? Well, thank you guys. Thank you.
Did I get all the raffle tickets? I need prize drawing. I can't say rep.